Hello, my name is Ihab Dawood. I'm an associate professor in medicine in Jepsen School, University of Hawaii, and today we'll be talking about ventilator-induced lung injury. Before the talk, I want to thank Essential Series and the ESAAC, along with Dr. Safa Hilal and Dr. Abdurrahman Abu Shadi for inviting me. And the talk again will be about ventilator-induced lung injury or VILI. Our learning objectives today will be to talk about what are the types of ventilator-induced lung injury, and there's so many right now. How do we diagnose them, and what's our strategies to avoid ventilator-induced lung injury? And we'll touch base on individualized ventilation strategies, as not only one strategy can reduce ventilator-induced lung injury. I want to start by talking about what's the incidence or the prevalence of ventilator-induced lung injury in the ICU. And to be honest with you, we don't 100% sure know, and that's because of the difficulty in diagnosis. And I like this picture and that blog. You see the link below. I think of it as an unseen elephant of the room, where it is there, but unfortunately we cannot see it or diagnose it. So what's again the incidence and the prevalence of ventilator-induced lung injury? And it's really hard to estimate, but that's what's available in the literature so far. That patients without initial lung injury, approximately 25% of the patients who had healthy lungs when starting mechanical ventilation would develop some evidence of ventilator-induced lung injury within the first 5 days. How about in ARDS patients who already have lung injury? The incidence is probably much higher, but the exact percentage again is unknown because it's very widely, because ventilator-induced lung injury overpresents as progression of the ARDS itself. In the general population in the United States, the estimated number ranges from 41 to 57 cases per 100,000 population, which again, I really think this is a very underestimation of the number. During the COVID, the research showed that ventilator-induced lung injury was more frequent in those patients, with over 50% of ventilator-associated events in these groups attributed to progressive lung damage, probably exacerbated by the mechanical ventilation. But I want to also caution here that the term ventilator-associated events not exactly is ventilator-induced lung injury. It could include ventilator-associated pneumonias or other reasons. So sometimes you hear the term ventilator-induced lung injury, and sometimes ventilator-associated lung injury. We wrote this debate in the Journal of Mechanical Ventilation. The link is below, where each author describes why it should be named either VILI or VALI, and what's the significance of the name difference. Is there any significance versus just semantics? But ventilator-induced lung injury is basically the lung injury inflicted or aggravated by mechanical ventilation during treatment, and it can occur during invasive as well as non-invasive ventilation, and contribute significantly to the mortality and the morbidity of those critically ill patients. Before we dig deeper into the etiology and the types of ventilator-induced lung injury, I think it's worth it to talk a little bit about the term stress and the term strain, because they're related to lung injury. So stress is the force per unit area that has the same amount unit measurement as pressure. So basically a pressure applied to part of the lung, and that pressure that most closely correlates with the lung parenchymal stress is the transpulmonary pressure. If you have an esophageal balloon and you're monitoring it, we use the other alternative, the driving pressure or the tidal pressure, as a surrogate for stress. How about strain? Strain is the change in the lung volume relative to the resting volume, so the deformation of the alveoli each breath. So the formula for it, or description, is the tidal volume over the functional residual capacity of the lung, or the end expiratory lung volume. So to continue talking about the stress and strain, there is a relationship between the stress, and which is the pressure, as we said before, and the strain, which is the tidal volume over the functional residual capacity. And to be noted, if you can see this picture on the right side, this relationship is not linear. So that graph plots the transpulmonary pressure in centimeter water, which is again the stress on the y-axis, against the strain, which is again the tidal volume relative to the functional residual capacity during inflation, during inspiration. So the lower bottom quarter, the green area, that's represents a safe zone where alveoli are recruited and ventilated within physiological limits. If you go up on the curve in that yellow area, it corresponds to risk of overdistension, and that other red or pink shaded area indicates that will be risk of alveolar injury. So if you can notice, the higher the stress and the strain, we're subjecting that lung for some injury. So lately there's been talk about something called stress multipliers. What does that mean? It means that, if you can see in that picture, the consolidated alveoli in the middle of that picture, the blue, causes geometrical deformation of the normal neighboring aerated units. So applying a tidal volume amplifies this deformation, increasing the regional alveolar stress and strain. And the concept of stress multipliers is based on the biomechanics of non-uniform elastic material. We know that our lung is markedly heterogeneous and not a uniform structure. So when the distending force from the ventilator is applied to the lung, the stiff collapsed areas do not open up, causing the neighboring or the adjacent alveoli, which are more compliant, to stretch disproportionately, so increasing the stress and strain in those units. So let's talk about the classification of ventilator-induced lung injury. And in the past, we used to only think about Viotrauma and Biotrauma. Nowadays, we have so many, and probably more will come over time as more we understand. So Viotrauma is just, as we all know, based on high tidal volume that can injure the lung. Biotrauma, high driving pressure or transpulmonary driving pressure that can cause air leak, like pneumothorax or pneumoperitoneum. Atelectotrauma, which is the repeated opening and closing, and that's basically related to the PEEP setting or inappropriate PEEP setting, I should say. Biotrauma, it's also the release of mediators from the lung in response to, that can cause injury to other organs, even more injury to the lung too. Ergotrauma, over the last decade, we've been talking about ergo meaning energy, so it's related to the mechanical power, and we'll touch base on it. Chronotrauma, which is kind of a new name, and I want to talk about this a little bit when we come to it. It's basically related to the respiratory rate, and something that we don't think about that much is how respiratory rate is related to lung injury. And in the past, during the low tidal volume era and the ARMA trial from the ARDS, when the patient become hypercapnic, our always reflexes is just to increase the respiratory rate. And I think that was probably the wrong thing to do, because high respiratory rate is definitely related to increasing the mechanical power and the energy from the ventilator. Rheotrauma is just deformation of the alveoli related to the flow. Ventilator-induced diaphragmatic dysfunction, or VIDD. So this is diaphragmatic weakness or injury caused by the ventilator. And the PEEP, or patient self-induced lung injury. And again, we'll talk about this in a little bit. This picture is just a nice illustration, a little bit of what we're talking about. You can see here the Viotrauma, the Rheotrauma, Biotrauma, Atelectotrauma, Biotrauma, and of course on the top of it you can have ventilator-associated infections or pneumonia. We'll talk about each topic separately. So let's take the types of ventilator-induced lung injury one by one. And let's start by Viotrauma. We all know that it's the injury caused by over-distension of the lung during mechanical ventilation, and it's a constraining physical limits of the lung structure is achieved at the total lung capacity. Now the damage occurs if the energy applied distends the lung repeatedly above its limits through microfracture of the extracellular matrix, causing inflammatory signaling and vascular stress that leads to tissue wounding and inflammatory activation. And we all know also in ARDS or lung injury already, the lung size is limited and smaller, what we named the baby lung. So you don't have to put tidal volume above the total lung capacity. Sometimes much smaller tidal volumes can cause lung damage. The second type of ventilator-induced injury that we are all familiar with is Biotrauma. And Biotrauma refers to the lung injury caused by the excessive airway pressure, as we talked before, which is considered to be the stress on the lung tissue. When that pressure gradient across the alveolar wall, like the transpulmonary pressure, which is the difference between the airway pressure or the alveolar pressure minus the pleural pressure or the pressure from outside, exceed the structure integrity of the lung tissue. It causes alveolar rupture, allowing the air to escape into the extra-alveolar spaces, leading to pneumothorax, pneumomediastinum, or subcutaneous emphysema. Atelectrauma is one of the recently names of ventilator-induced lung injury, and I put under it PEEP because it's caused by insufficient PEEP. So atelectrauma occurs in collapsed alveoli when the tidal pressures are sufficient to inflate the collapsed alveoli, usually during inspiration, but then collapses again during exhalation because of insufficient PEEP. This cyclical recruitment and de-recruitment creates a shear force that injures the alveolar epithelium, disrupting the surfactant function and triggering a pro-inflammatory cascade, leading to increased capillary permeability and edema. And the more the lung gets atelectatic, it becomes more edematous, increasing the weight, further contribution to regional atelectasis, creating this vicious cycle. Ergotrauma, which is also one of the newer names over the last decade or so, and ergotrauma refers to the energy delivered to the respiratory system, or more importantly to the lung, and that we calculated by the mechanical power, or refer to it as the mechanical power. Mechanical power is the total energy delivered per minute, measured as joules per minute to the respiratory system, and mechanical power is basically the respiratory rate times the pressure times the tidal volume times that conversion factor of 0.098. This is mathematically the best way to measure the mechanical power or the energy delivered to the lung is to calculate the area under the curve of the volume pressure curve. So if you see the bottom figures here, the one on the left is for a volume controlled ventilation with constant flow, and we can divide the energy into elastic energy in blue and resistive energy in yellow. The elastic energy we can further divide it into static, which is the PEEP, and tidal. If you look at the picture in the middle, that's the pressure volume curve of pressure control ventilation, and again the yellow is resistive and blue is the elastic, and the right side is just during unassisted ventilation, again blue resistive and the blue is elastic, and there's no PEEP here if you notice, because we're not supposed to have auto PEEP or spontaneously breathing, unless of course there is obstructive element. As I was saying before, the mechanical power is basically the energy coming from the ventilator into the lung. And in that video from the infamous Rocky movie, where he's getting hit multiple times, being punched, so think of him as the lung, and the punches thrown at him is from the ventilator. So how many times he gets punched, that refers to the respiratory rate. How strong are the punches are the driving pressure, and how far his head bubbles after being hit, which is the tidal volume or the flow. So mechanical power basically combines the major causes of ventilator into lung injury into one component or one measurable component. Biotrauma refers to the systemic inflammatory response incited by the physical forces of ventilator-induced lung injury. So when the lungs start getting injured, regardless with over distension or at electrotrauma, it triggers the release of pro-inflammatory mediators like tumor necrosis factor alpha, interleukin 6, interleukin 8, the MMP9 and nuclear factors, tumor necrosis factors, multiple cytokines. This cascade can happen pretty quickly and causes a picture of systemic inflammation or sometimes distributive kind of shock. So lung infiltrate, fevers, hypotension, almost similar to sepsis. Rheotrauma is also a newish name, which refers to the lung injury caused by the high gas flow rates delivered during mechanical ventilation, rather than just the pressure or the volume alone. So the high flow rates creates turbulence and shear stress within the airways, which can be transferred to the lung matrix itself, damaging the lung tissues. We also all know about patient self-induced lung injury, or PEEP, and it's caused by the cyclical fluctuation and the regional heterogeneity in the transpulmonary pressure, usually driven by the excessive patient respiratory effort, and this was noticed during COVID time. It can happen during unassisted spontaneous breathing or in conjunction with mechanical ventilation. What happens is, because of the lung is so heterogeneous, if you look at that figure on the right, and difference in the transpulmonary pressures, say from the good parts on the top to the bad parts on the bottom, so causing the pendelluft that we talked about earlier, pendelluft phenomena, causing further lung injury and microvascular damage. The pendelluft phenomena is the movement of gas within the lung from one area of the lung to another area during the same breath sometimes, and can happen during inspiration and or expiration. And this is one of the causes of patient self-induced lung injury. So usually it happens from areas of air going from low time constant areas to relatively higher time constant, and again it can happen in the opposite direction. So if you look at that figure, you can see the air going from the top, the non-dependent areas, to the dependent part where usually the compliance is very bad, so can cause over distension, increased stress in those areas. So we don't want to forget one of the bad effects of mechanical ventilation on the diaphragm, our major respiratory muscles, and that's called ventilator induced diaphragmatic dysfunction, or VIDD. Of course, diaphragmatic atrophy and injury can cause by the ventilator, by medications like steroids or antibiotics. Sepsis or malnutrition can be contributing too, and they all cause mitochondrial oxidative stress and inflammation, leading after all to muscle atrophy and contractile dysfunction. The diaphragm loses its muscle strength and fiber size start to atrophy, specifically because of the mechanical ventilation. The problem is it causes weaning failure and prolonged hospital stay, increased mortality in critically ill patients. And you can evaluate this usually by the diaphragmatic ultrasound. Now let's talk a little bit about diagnosis. And the problem for diagnosis is there's no gold standard for diagnosis, so it's mostly diagnosis of suspicion. Clinically, the patient might start getting worse oxygenation with new infiltrates on chest x-ray or CAT scans, might get some fevers, sepsis-like pictures, and you probably need to rule out other diagnoses like ventilator-associated pneumonia. Problem is there's also no biomarkers available in clinical practice, mostly in research for now, but I'm pretty sure some biomarkers will be available soon. As we said, the biomarkers are not standard for routine diagnosis yet, but some elevated levels of inflammatory cytokines like interleukin 6 or 8, tumor necrosis factor alpha, or epithelial injury markers like the soluble receptor for advanced glycation end products can indicate active biotrauma. So since there is no specific treatment and the difficulty of diagnosis, probably the most important thing and the thing that we can do is to prevent ventilator-induced lung injury. So this slide kind of include a lot of things, and then we'll talk about specific things that we can do one by one. We all know that in ARDS or lung injury, the FRC of the lung is reduced and the baby lung. So we need to reduce the stress and the strain, basically the tidal volume and the driving pressure, as mentioned before. But also minimizing and treating dyssynchrony is important. Monitoring and the inspiratory effort of the patient is also very important. Taking care of PEEP, trying to use appropriate PEEP, because excessive PEEP can cause over distension, as you can see here on the left side of the picture, the right lung. Excessive PEEP can cause over distension, and insufficient PEEP can cause de-recruitment and atelectotrauma. Also, you have to be careful about the patient's self-induced lung injury, again with the patient effort and high drive, and diaphragmatic injury also. High effort and high drive can cause diaphragmatic weakness, and low effort or high assistance from the ventilator can cause disuse, atrophy, and decrease effort too. So let's start talking about the tidal volume, and we know that we should be using the lowest possible tidal volume for ventilation and allow for permissive hypercapnia. The problem with the tidal volume is we ignore the dead space, and we all know that even in normal lungs, almost 1/3 of our tidal volume going to the dead space and does not reach the alveoli. So, and in ARDS or other lung pathologies, that space is increased, especially in using mechanical ventilation and with airways and tubes and capnometers and all this stuff can worsen the tidal volume, the dead space. So we should focus more on the alveolar dead space. And how can we measure alveolar dead space? If you look at this picture, is using volumetric capnometry. So if you can see on this picture, the first arrow here, that's the anatomical dead space, and then the rest of it is a alveolar dead space. And even the alveolar tidal volume. And even the alveolar tidal volume measured by the capnometry, part of it is alveolar dead space. So at least we should be checking the alveolar tidal volume more importantly than just the total tidal volume. Driving pressure is also probably one of the very most important ones in ventilator-induced lung injury prevention. And we know that the current studies and research is recommending to lower the driving pressure below 15 centimeter water. I would go further and say it's probably the transpulmonary pressure is more important, because this is the real stress on the lung itself, not on the whole respiratory system. And to do that, you have to use an esophageal balloon, as you can see in this picture, the airway pressure on the top, and esophageal pressure as a surrogate of the pleural pressure in the middle, and the lower part with the blue arrow is the transpulmonary driving pressure, basically the airway pressure minus the pleural pressure, and the transpulmonary driving pressure will be the end inspiratory pressure minus the end expiratory pressure. Those two figures below illustrate why the airway pressure alone, or the airway driving pressure alone, might be tricky and not sufficient. So let's take a look at the first figure on the left. I know it's kind of hard to read, but you start from a PEEP of like about 10, and the driving pressure is about 15, I think less than 15 in that figure on the top. But if you look at the transpulmonary pressure, which is the third one here under the flow and number 3, you can see, because the patient is actively breathing hard, in the bottom one, the esophageal pressure, you can see during inspiration, the esophageal pressure goes from 15 to like -5, so resulting in a transpulmonary pressure very high, about 35. So despite that the driving pressure looks okay and about 15, the transpulmonary pressure is probably injurious. Now the opposite of it, let's take a look at the right side graph here. Here the airway pressure is probably high. We're starting from PEEP of 20 and going to up of driving pressure of 40, so the driving pressure is about 20, which again higher than the recommended by the literature. But let's take a look at the third row here. That's esophageal pressure, and during inspiration it goes up to 30. So this patient has high elastance of the chest wall, so that's why the pleural pressure is high. So if you calculate the transpulmonary pressure at the bottom here, you would see that the end inspiratory pressure is 10 and the end expiratory pressure is 0, so the transpulmonary driving pressure is only 10. So despite high driving pressure, airway pressure, the transpulmonary pressure is okay. And that highlights why using the transpulmonary pressure gives you a more insight on ventilator-induced lung injury than just the airway pressure. Another very important, probably one of the most important parts of ventilator-induced lung injury prevention is setting the PEEP. And setting the PEEP is really challenged during mechanical ventilation. And the problem of PEEP is there's so many studies about how to set PEEP, but there is no agreement on how and what is the best way of doing it. Since the ARMA trial and ARDS network, and they proposed the PEEP FiO2 tables, which, to be honest with you, I never ever use them, and I think they are very non-physiologic, so I never use them. We try to use personalized PEEP. Every lung is different, so we try to get, I would say, the optimal PEEP, not best PEEP, according to some parameters. So let's say, why do we need adequate or optimal PEEP? Because it's not only all about oxygenation. You want to avoid alveolar collapse at the end of expiration to prevent atelectasis trauma. You want to open that lung up and get to operate on the best compliance, and you also want the least hemodynamic negative effect of PEEP, and probably oxygenation too. So how are we gonna do this? And there is like more than 20 ways of setting the PEEP, and there's thousands, not even millions of studies about it. What I try to do is I try to get this pressure volume curve, a quasi-static one. Usually the patient need to be heavily sedated or paralyzed to get pressure volume curve, and I try to set the PEEP according to the low inflection point or the airway opening pressure and the inspiratory part or the best hysteresis. And that also, that curve helps you to decide whether this lung is recruitable or not. And you can do recruitment maneuver with it. So PEEP in general is very long talk by itself. One of the other things that I try to do is also using the esophageal balloon to try to set my PEEP above the esophageal pressure during expiration, aiming for about 0 transpulmonary and expiratory pressure in that middle picture here. EIT nowadays is emerging, very good tool at the bedside, and you can estimate or adjust PEEP to prevent over distension caused by PEEP and atelectasis also caused by low PEEP. So if you look at the figure here, the bottom one, on the left side, that light blue is over distension, and while coming down on the PEEP, you can see dark blue start to occur. So you want to set your PEEP somewhere here where there is the least over distension and the least atelectasis. Then other ways of setting PEEP, like decremental or incremental to the best compliance and so forth. One component that goes mostly overlooked is the respiratory rate. And if you remember again, during the ARDS network studies, they allowed to increase the respiratory rate to 30-35 for the hypercapnia that happens with the low tidal volume. We now, I think, opening our eyes to know that high respiratory rate can cause lung injury. And if you remember a couple of slides ago, we talked about the mechanical power, and we said that every respiratory rate, it's a new punch to the lung. So respiratory rate is one of the independent factors in mechanical power, and the more we give the respiratory rate, we're increasing the mechanical power and the ergotrauma. So respiratory rate directly increases the intensity and susceptibility to ventilator-induced lung injury by increasing the mechanical power and the number of stress cycles applied to the lung parenchyma. Additionally, like higher respiratory rates can cause auto PEEP and also can injure the diaphragm too. So we have to use the lowest respiratory rate possible, to reduce the risk of lung injury. So the mechanical power, again, we talked about it briefly, and we again agreed that it's a component of the tidal volume the driving pressure and the respiratory rate, and the area under the curve of the volume pressure curve. So we need to start targeting mechanical power, and how to reduce the mechanical power by using the lowest respiratory rate possible, the lowest tidal volume possible, the lowest driving pressure possible, and the lowest possible PEEP. And by this I have to be careful, because we can say, okay, let's put the PEEP to 0 and that would reduce the mechanical power. No, I'm still saying not use the PEEP FiO2 table, avoid very high PEEP that can cause over distension, and use the adequate PEEP. In our Society of Mechanical Ventilation, we have a page for calculators of how to calculate the mechanical power. We have many formulas that have been published in articles now. So if you go to societymechanical-ventilation.org/calculators, you can start calculating the mechanical power. Lots of studies said about try to get the mechanical power below 15 or 17, but again, if you can try to get it much below that, that would be great too. Another simple way of preventing a ventilator-induced lung injury is proning. Unfortunately, we use proning only when the patient is very sick, very hypoxic, but we all know the benefits of proning, that it improves the lung homogeneity, it improves the compliance, oxygenation, improves the right ventricle and the pulmonary vascular resistance, and it improves mortality. So when you improve the compliance and the oxygenation, you would find yourself using less tidal volume, less driving pressure. So proning itself can be very beneficial to prevent ventilator-induced lung injury. Dyssynchronies can play an important role in ventilator-induced lung injury, and dyssynchronies is a very big topic, so we can't go through it right now, but I just want to tell you, keep an eye on them and try to correct them. And there's a lot of resources about patient-ventilator interaction and dyssynchronies. Those cards here are from Hamilton Medical website and free for download. So try to see how can you detect dyssynchronies and try to correct them, and that should help in preventing ventilator-induced lung injury. Another way of trying to prevent ventilator-induced lung injury is the neuromuscular blockers, and some studies showed that it might improve mortality and some didn't show it, especially early in ARDS. Is that related to ventilator-induced lung injury prevention? It's very possible, because paralytics would decrease the transpulmonary pressure when you take the patient effort away, and also can prevent dyssynchronies. So theoretically, paralytics can be useful in ventilator-induced lung injury prevention, especially early. I think we talked about the esophageal balloon a couple of times, and you can tell that I'm a fan of using it. How can it prevent ventilator-induced lung injury? As we talked before, you can measure the transpulmonary pressures, the transpulmonary and expiratory pressure, and try to keeping it above 0 to prevent atelectotrauma, and also the transpulmonary driving pressure to decrease the stress on the lung. You can use it to measure the transpulmonary mechanical power, which is again more the mechanical power on the lung itself, not just on the whole respiratory system. You can use it to set the PEEP, and to manage dyssynchronies, detect and manage dyssynchronies. So there is a lot of benefit in using the esophageal balloon as a preventive measure for ventilator-induced lung injury. We talked about EIT before, electrical impedance tomography, and how can it help. Again, it can help us by recognizing over distension, can recognize alveolar collapse and setting the PEEP. It can help with recognizing the pendelluft phenomena and even in dyssynchronies too. So new emerging tool that can be beneficial at the bedside. There's no really studies as of yet to see would it be using the EIT might improve mortality or not. We'll see. For treatment, unfortunately, there is no specific treatment. Just prevention is very important and supportive care. And my message to you is personalized ventilation. Not all lungs or cause of respiratory failure can be managed by just one strategy. Well, let's give the patient what they need regardless, tidal volume, driving pressure, PEEP, etc. With this, I'm going to end my talk, and I want to thank you all for listening. And I appreciate being here. Thanks for the invitation. And if you have time, please check the Journal of Mechanical Ventilation and Society of Mechanical Ventilation. You might find some materials there that might be helpful. Thank you again, and have a good night.